Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to Transforming Healthcare. Position your hospital for success and pay for performance. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Deborah Smith. Ms. Smith, the floor is yours.
Thank you, Ryan. And good afternoon, everybody. I am Deb Smith, the Infection Preventionist for VHQC, and on behalf of VHQC, Maryland, Virginia HAI Improvement Network, I want to welcome you all to our webinar, Transforming Healthcare, Position Your Hospital for Success and Pay for Performance. So, of course, before we get started with our webinar today, we do have a few housekeeping items. You heard Ryan tell us all lines are on mute for today. And we'll be opening the lines up at the end of both presentations for your questions. So in order to make sure that we can get all of your questions, we are asking you to please type them in chat as you think of them as the webinar progresses. We'll send answers to any questions that we do not have time for today, along with your recording link, approximately a week after this webinar. You can access the chat box by clicking the chat icon in the upper right-hand corner of your screen. Carol Whalen, Improvement Consultant for Maryland Providers, will be monitoring the chat during the call. You can also use chat to send any comments to the group. There'll be a short evaluation at the end of the webinar, so please take time to answer the questions and give us your feedback, positive and negative. We take this feedback seriously in order to keep improving our calls and webinars. We want them to be as useful as possible. So I'd now like to introduce our first speaker for today. Sandy Gaskins is the VHQC Improvement Consultant working with providers in Virginia with the CMS Value-Based Purchasing Program. She'll be explaining the Virginia Pay for Performance measures. We also have Diane Feeney of the Maryland Health Services Cost Review Commission with us, and she will follow Sandy's presentation with Maryland's Quality-Based Reimbursement Program. So, Sandy, the floor is now yours.
Thank you, Deb. Welcome, everyone, and thank you for taking the time to join today's presentation. As Deb mentioned, my name is Sandy Gaskins, and I'm an improvement consultant with VHQC. Next slide. So to get started, a brief overview. The Hospital Value-Based Purchasing Program is required by Congress under Section 1886 of the Social Security Act as added by the Patient Protection and Affordable Care Act. The program is a CMS incentive program that builds on the Hospital Inpatient Quality Reporting Program. Before a measure can be included in the Value-Based Purchasing Program, it must have been displayed on the Hospital Compare website as an inpatient quality reporting program measure for at least 1 year prior to the beginning of a value-based purchasing performance period. The Hospital Value-Based Purchasing Program is the first national inpatient pay-for-performance program in which hospitals are paid for services based on the quality of care rather than the quantity of care. CMS has used value-based purchasing as an important driver of change, moving towards rewarding better value and improved patient outcomes, which in turn leads to better care and healthier patients. The program is budget neutral and is funded by a reduction in the base operating DRG payment of all participating hospitals. As noted in the graphic, the percentage of payments withheld has increased from 1% in fiscal year 2013 to 2% in fiscal year 2017. Next slide. Not every hospital is eligible for the CMS Hospital Value-Based Purchasing Program. The program only applies to general, short-term, acute care hospitals, commonly referred to as CMS Subsection D hospitals. Subsection D hospitals may be excluded from the program for one of the following reasons. Hospitals or hospital units excluded from the inpatient prospective payment system, such as critical access hospitals, are all excluded from value-based purchasing. If a hospital receives a reduction in their annual payment update for either not participating in the hospital inpatient quality reporting program or not meeting the requirements of the hospital I2R program, they will also be excluded from the value-based purchasing program and will not incur the withhold from their base operating DRG for the fiscal year. Also excluded from the VBP program are hospitals that were cited for 2 or more deficiencies during the value-based performance period, hospitals with less than the minimum number of VBP domains calculated, and short-term acute care hospitals in the state of Maryland. Next slide. Eligible hospitals will earn a value-based incentive payment based on the hospital's total performance score. To arrive at the hospital's total performance score, you start with the individual measure score. A hospital may earn 2 scores for each value-based purchasing measure based on either achievement or improvement. If a hospital's measure performance during the VBP performance period is better than the national achievement threshold, the hospital will earn 1 to 10 achievement points. If a hospital's measure performance during the value-based performance period improves from the baseline period measure performance, the hospital will earn 1 to 9 improvement points. The final measure score awarded to the hospital is the higher of these 2 scores. The individual measure score rolls up to the VBP domain score. Each domain has eligibility requirements that specify the minimum number of cases, surveys, episodes, predicted infections, and measures required in order for a domain score to be calculated. Once calculated, the domain score is then weighted and rolled up to the total performance score. The total performance score is then translated into a value-based incentive payment factor that is applied to each Medicare claim submitted to CMS by that hospital. Next slide. The Inpatient Prospective Payment System final rule defines the details of the value-based purchasing program each year. This year, 2015, is the value-based purchasing program performance year that will be used to calculate your hospital's value-based incentive payment factor that will be applied to discharges for fiscal year 2017, which begins October 1, 2016. It's important to note that the value-based purchasing program has evolved over time since its beginning in fiscal year 2013. In 2013 fiscal year, there were only 2 domains: clinical process of care domain, which was weighted at 70% and consisted of 12 inpatient quality reporting program process of care measures. And the other domain was the patient experience of care domain, weighted at 30%. For fiscal year 2017, there are 4 domains: the clinical care domain, which includes 2 subdomains: outcome, weighted at 25%, and process, weighted at 5%. The patient and caregiver-centered experience of care coordination domain is weighted at 25%. The safety domain, weighted at 20%, and the efficiency and cost reduction domain, weighted at 25%. Next slide. Although the focus of today's presentation is on the value-based purchasing safety domain and the associated healthcare-associated infection measures, I did want to provide a quick overview of the other 3 domains included in the value-based purchasing program. The clinical care process subdomain for fiscal year 2017 includes only 3 inpatient quality reporting program process of care measures. This is a significant change when you consider that in the first year of value-based purchasing, the clinical process of care domain was weighted at 70% and included 12 process of care measures. VBP process of care measures for fiscal year 2017 include AMI 7A, immunization 2, and new this year, the PC01, elective delivery prior to 39 completed weeks gestation measure. The graphic displays the established measure achievement thresholds and benchmarks, as well as the measure baseline and performance periods. The clinical care outcome subdomain includes 3 of the claims-based, condition-specific, 30-day risk standardized mortality measures including acute myocardial infarction, heart failure, pneumonia. Baseline and performance periods are noted, as well as measure thresholds and benchmarks. Included at the bottom of the slide are the eligibility requirements for calculating an improvement score, achievement score, and clinical care domain score. I would like to note that this past Friday, April 10th, CMS uploaded your hospital-specific value-based fiscal year 2016 preview data for the value-based purchasing claims-based measures, mortality, and the AHRQ PSI 90 composite score measures. This is a downloadable report available to you via the QNet Secure Portal. Next slide. The patient and caregiver-centered experience of care coordination domain. This domain is measured by using the Hospital Consumer Assessment of Health Providers and Systems, or HCAHPS, survey dimensions. The dimensions include communication with nurses, communication with doctors, responsiveness of hospital staff, pain management, communication about medication, cleanliness and quietness, discharge information, and overall rating of hospital. The baseline period is calendar year 2013, and performance period is calendar year 2015. The established achievement thresholds and benchmarks are noted for each of the HCAHPS dimensions, as well as the floor percentage. The floor is what's used when calculating the HCAHPS consistency score. It's the lowest performing hospital during the baseline period. Noted at the bottom of the slide are the eligibility requirements for this domain. Next slide. The efficiency and cost reduction domain currently includes only one claims-based measure, the Medicare Spending per Beneficiary measure, or MSPB measure. This measure assesses Medicare Part A and Part B payments for services provided to Medicare beneficiaries during a spending per beneficiary episode that spans from 3 days prior to an inpatient hospital admission through 30 days after discharge. The achievement threshold is the median MSPB ratio across all hospitals during the performance period. Benchmark is the lowest decile of MSPB ratio across all hospitals during the performance period. For this measure, lower rates indicate better quality. The VBP baseline period has been set at calendar year 2013 and performance period is calendar year 2015. Again, eligibility requirements are noted at the bottom of the slide. Next slide. And that brings us to value-based purchasing safety domain, weighted at 25%. Next slide. Although the safety domain is new to the value-based purchasing program, the 6 measures in the domain are not. The AHRQ Patient Safety Indicator 90 composite score and the central line-associated bloodstream infections among adult, pediatric, and neonatal ICU patients, HAI measure, were both included as a value-based measure in the VBP payment year 2015, but they were grouped in the VBP outcome domain. In payment year 2016, CMS added 2 additional HAI measures, CAUTI and surgical site infections, specific to abdominal hysterectomy and colon surgery. Again, all of these measures remained in the outcome domain of VBP. With this year, CMS moved the above measures from the outcome domain to the newly created safety domain. In addition, 2 HAI measures were added to the value-based program, MRSA and Clostridium difficile infection. Next slide. The HAI measure performance is based on the standardized infection ratio, or the SIR. The SIR is a risk-adjusted summary measure. It is a ratio that compares the observed number of HAIs to the expected or predicted number of HAIs. The observed number is the number of events your hospital enters into NHSN, and the expected or predicted number of HAIs comes from the national baseline data from CDC. So if a hospital SIR equals 1, the number of observed events and the number of expected events is equal. If the SIR is greater than 1, then there are more infections reported than what was expected. If the SIR is less than 1, there are fewer infections reported than what was expected. For the value-based purchasing fiscal year 2017, the baseline period for the HAI measures is calendar year 2013, and the performance period is calendar year 2015, this year. The AHRQ PSI 90 composite measure is a claims-based measure. It is a composite score that is the weighted average of 8 individual patient safety indicators. Baseline period is a 21-month period from time between October 2010 through June 2012, and performance period is October 2013 through this June. Next slide. The established VBP fiscal year 2017 HAI achievement threshold SIRS and the benchmark SIRS are noted in this table, along with a reminder that lower rates are better for this VBP measure. The achievement threshold is calculated as the median or 50th percentile of all hospital rates during the VBP baseline period, calendar year 2013. And the benchmark is the mean of the top decile, which is the average of the top 10% during the baseline period. As you can see, the benchmark for all of the HAI measures is 0.000. Next slide. So as I noted earlier, the hospital may earn 2 scores for each VBP measure based on either achievement or improvement. The final measure score awarded to the hospital is the higher of the 2 scores. Achievement points are awarded when your hospital SIR during the performance period for the HAI measure is equal to or better than the achievement threshold for that HAI. If during the performance period your hospital SIR for an HAI measure was at benchmark, your hospital would earn 10 achievement points for that HAI measure. If the SIR during the performance period was somewhere between the achievement threshold and the benchmark for the HAI measure, your hospital would earn 1 to 9 achievement points. And if the SIR is less than the achievement threshold, no points are earned for that HAI measure. Next slide. Improvement points are awarded when your hospital SIR during the performance period is better than your hospital SIR during the baseline period. If the SIR during performance period did not improve from your hospital's baseline, your hospital would earn 0 improvement points for that HAI measure. If the SIR during the performance period falls somewhere between your baseline period SIR and the measured benchmark, your hospital would earn 0 to 9 improvement points for the measure. If the SIR during the performance period is at benchmark and improved from baseline, your hospital would earn 9 improvement points. Next slide. This slide displays scoring requirements associated with this safety domain. The hospital must have at least 1 predicted and or expected infection calculated by the CDC during the baseline period in order for an improvement score to be calculated. In addition, the hospital must have at least 1 predicted and or expected infection calculated by the CDC during the performance period in order for an achievement and or an improvement score calculated for the measure. In order for the safety domain to be included in the value-based purchasing program total performance score, at least 3 of the 6 measures in this domain must be scored. The individual measure scores are then added together, divided by the total possible points, and multiplied by 100 to arrive at the domain score. The safety domain is weighted at 20% and rolled up to the hospital's total performance score. As I noted in an earlier slide, at least 3 of the 4 VBP domains must be scored in order for a total performance score to be calculated for the hospital. Next slide. The hospital-specific baseline measures report for value-based purchasing became available on February 24th. The report is available to you via the Report Run application of the QualityNet Secure Portal. We encourage you to run your hospital-specific VBP baseline report if you haven't already done so. If you need instructions or you need assistance, please give me a call or the QNet help desk. Next slide. Displayed is an example of the HAI data available to you via the VBP baseline measures report. The report provides you with your hospital-specific individual baseline SIR for each of the HAI measures included in the VBP program. Using this displayed sample report, and the numbers are very small, so I don't think you're going to be able to see this, but in this particular example, the hospital's CDI SIR during the baseline period is 1.026. The achievement threshold for this HAI measure is a SIR of 0.750, and benchmark SIR is 0.000. For this hospital to earn 1 to 10 achievement points, their CDI SIR during this calendar year would need to be equal to or less than 0.750. For the hospital to earn 1 to 9 improvement points, their CDI SIR would need to be less than their baseline period SIR of 1.026. Next slide. And in addition to value-based purchasing program, your hospital's HAI SIR also plays a significant role in the CMS, Hospital Acquired Condition, or HAC, reduction program. Fiscal year 2015 was the first year of this CMS penalty program that reduces the base operating DRG payment of those hospitals that rank in the lowest performing quartile during the specified performance year. This penalty program has 2 domains and uses measures that are already part of the hospital inpatient quality reporting program. Fiscal year 2015 included the PSI 90 composite score as well as the Class D and CAUTI SIR. In fiscal 2016, the program measures expanded to include surgical site infection SIR. In addition, the HAI domain weight increased to 75%. Next slide. You are not alone in your efforts to reduce healthcare-associated infections. Displayed are a number of organizations, associations, and agencies from across the states of Virginia and Maryland that are working together and with hospital infection preventionists to reduce HAIs and improve the quality of care provided to patients. Next slide. Displayed are a number of links that I wanted to provide to you with resources and tools that can assist you in your efforts. Next slide. And I also wanted to share the contact information for the VHQC HAI Network Improvement Consultants, Deb Smith in Virginia, Carol Wayland in Maryland, and myself here in Richmond. We're now going to hear from Diane Feeney with the Maryland Health Services Cost Review Commission, who will share information regarding the unique all-payer rate setting system in Maryland and the incentive programs they oversee. To introduce you, Ms. Feeney is the Associate Director of Quality Initiatives at the Maryland Health Services Cost Review Commission and responsible for the development and implementation of quality initiatives focused on improving processes of care, patient outcomes such as complications and mortality, and improved care coordination and handoffs that reduce admissions. Ms. Feeney's prior healthcare experience includes middle and executive management, performance improvement, senior consulting, and clinical instructional and case management nursing with comprehensive expertise in the areas of healthcare quality and safety, public policy, and program implementation for high-needs populations. Diane?
Yes, thank you so much. And thank you for your presentation because it was a perfect entree to what I'd like to discuss about the Maryland program. Because you so eloquently described and clearly the measures and the domains, what I'd like to do is just point out as I go through my slides where the Maryland program differs from the federal value-based purchasing program. And then as you mentioned, I would also like to point out a couple of the other incentive-based programs that are currently implemented in the state of Maryland. So by way of just a little background and history, Maryland implemented its QBR quality-based reimbursement program in 2010, and this program is analogous, but not exactly the same as the value-based purchasing program, which, as you mentioned previously, was implemented in 2013. Because of, as you mentioned also, the waiver in Maryland, which was from the Part D requirements for IPPS hospitals previously, Maryland was not required to comply with the value-based purchasing program. In January of 2014, another program agreement with the Centers for Medicare and Medicaid Innovation was established between Maryland and CMMI, such that there's a model agreement now, and it no longer falls under those Part D requirements. And under that model agreement, the entire state must submit a exemption request each year, demonstrating that we were similar to or better than the value-based purchasing program in terms of cost savings and quality. And so we have done that each year under the previous waiver and now under our new model agreement. Next slide, please. We do have a very robust stakeholder input process. We have a work group that's ongoing. We call it the Performance Measurement Work Group. That includes payers of public and provider types, public and private, sorry. That includes the Medicaid program as well as all the private payers in the state. And then we also have consumer representatives, but those inputs are through other types of work groups like the Consumer Engagement and Outreach Task Force. And then we have what we call a payment models work group. So we have many, many opportunities for stakeholders to weigh in either directly or indirectly to the performance measurement activities at the HSCRC. In our most recent meeting, or in our most recent recommendation related to updating the QBR program, the Maryland Hospital Association, MHA, did express concerns on behalf of the hospital industry that their magnitude of risk was being ratcheted up to 2% for the QBR program, and that was to be consistent with what was happening at the federal level with value-based purchasing. However, we must remember that 2% is of all inpatient costs, not just the base DRG, and it's for all payers. All of our programs apply to all payers, not just Medicare. And Medicare constitutes a little bit less than half of the cost of inpatient hospital care in Maryland. So there's a much greater amount at risk, if you will, when you consider 2% of a Medicare base DRG versus 2% of all inpatient costs and at an all-payer level. The hospitals also articulated concern that they really wanted to see how they were doing over time in the course of a performance year, rather than waiting to the end to see where they fell out, if you will, relative to their peers. So we have been working with the industry to figure out how to provide real-time incremental performance results so that the hospitals could measure how they were doing and how this would impact them financially. We've also, next slide, please. So here what I'd like to do is go through the measurement domains that, again, were already discussed. But here you can see we've defined our domains exactly the same as CMS, but the measures within these domains are not exact in some cases. So I'd like to just highlight those areas that are different. For the clinical measures, we do use the same process of care, and we are looking at those three measures to the extent that those are reported across hospitals. For outcomes, we do use a mortality measure, but instead of the three condition-specific measures, we do use inpatient mortality for the top 80% of APR-DRGs that cause mortality in the hospital. So it's a broader measure, but it doesn't extend as long as the 30-day. It stays to inpatient. And we use the 3M risk of mortality methodology in order to risk adjust those results. For patient experience, we also use the HCAHPS measures, the same as the CMS VBP program. And for the safety domain, we are a little bit behind on adding in CAUTI, but this coming year we are using CLABSI, CAUTI, The C. diff measure, I believe, is a year behind, and we will use the surgical site infection measure. And in terms of PSI 90, that's a measure that's different than what is used at the federal level. PSI is a claims-based measure, as we have already heard. We use our inpatient case mix data, which is analogous to claims data, to calculate the PSI 90 measure for hospitals, but we do it on an all-payer basis, not just on Medicare patients. So that is how that measure differs. You'll see how the domain weights are also different. We in Maryland, for instance, have a higher domain weight for patient experience, or HCAP, and at 45% compared to 25% for the Medicare program. And the issue with that is Maryland performs a little bit below what the national median or average performance is. So we are trying to increase the incentive to support a more rapid improvement on the HCAP measurement domain. You see that also for the efficiency measure, we do not have a medical care spending per beneficiary or a spending per beneficiary measure. The issue with that is that counts claims before and after a hospital episode, and we only have access to claims or claims-like data for the inpatient episode of care alone, so we are unable to calculate the same efficiency measure. We do, however, make an adjustment in our what we call our global budget revenue measurement, and that is what that is, and I will dwell on this very briefly, is each hospital has an established global budget within which they must live for a particular fiscal or what we call rate year. And within that, there is an adjustment for the cost of certain things like complications and prevention quality indicators, which are also on our defined measure sets. And the PQIs measure admissions that conceptually could have been prevented. So these are things like admissions for ambulatory sensitive conditions like asthma or heart failure or other type conditions. So we do make an adjustment, a small adjustment, less 0.5% or less, in the hospital's global budget allotment for a particular year based on historic performance on those measures and the costs related to those measures, again, complications and PQIs. And we can move forward to the next slide. You'll see also a comparison of the measurement domains. Again, this is just another view of the domains and the percentages allocated to each domain for the various measure sets. You'll see also that Maryland started behind the curve with the amount of revenue at risk for fiscal 15. It was 0.5% at risk, whereas CMS's value-based purchasing program was 1.5%. Fiscal 16, we were up to 1%. CMS was up to 1.75%, and now we have recently, it says proposed for fiscal 17, but we just had approved 2% revenue at risk. That is now lined up with the 2% of the BBP program, revenue at risk for this program. However, again, this is based on all payer inpatient, not just the base DRG for the Medicare patients. We can move to the next slide. What I'd like to talk about now is how we've done on the various measures in the particular domains. And you'll see the red is the national average. The national top 10% is the gray, and Maryland performance is in the white. So you'll see, for instance, overall recommended care in the process domains, that's heart attack, heart failure, pneumonia, surgical care. Maryland's doing a little bit better. But if you look across some of the particular domains for those clinical conditions, Maryland is doing better than the national average in some cases, but not as well as the national average in others, and then not in the top 10%. So we're sort of about middle of the pack, I would say, on these measures. Next slide. Also, for the safety domain, you'll see the red line going across. These are where the SIR of 1 in 3 of those measure cases, Maryland is doing better than 1, so we have less than expected infections. And in 3 of those cases, Maryland is having more than expected infections. For central line bloodstream infections, you'll note that we are well below the SIR of 1 for the nation, and this is a marked improvement over the last 3 to 4 years, where we've had a very robust healthcare-associated infection work group that has really worked to move the needle. Now, I will also add that for CLADI, surgical site, and C. diff, those measures are newly collected, and not all hospitals collect those measures, particularly like for colon and hysterectomy for surgical sites. So there may be a small N of hospitals collecting those measures. So you see performance that's above the SIR of 1. However, that may not be reflective of all of the hospitals. It certainly is not reflective of all of the hospitals' participation. And that was using the most recent data available on a website put out by Commonwealth. That's Why Not the Best. It uses the same CMS Medicare VBP measures, but it's in a very user-friendly way where we could compare ourselves to the nation. And this information also was reported to CMS so that we could demonstrate how we were doing on these measures with regard to our VBP exemption request that went in February of this year to CMS. We can move forward to the next slide. We also looked at the 30-day mortality measure. As I mentioned, we use inpatient mortality for the top 80% of DRGs, and CMS uses heart attack, heart failure, and pneumonia measures of 30-day mortality. And we do see that Maryland is certainly below the nation on all 3 measures, but not quite at the level of the top 10%. Next slide. For HCAP, we've already said that Maryland is a little bit behind the curve on those, and you'll see that all the white bars show that in each of the areas we do not do as well as the national average or the top 10%. More recently, we have seen an improvement in the discharge information measure in particular, because there's been a concentrated effort on this area with reducing readmissions in the state. We can move forward. So revenue at risk, we talked about 2% already, and we must, one of the reasons why we lined up with CMS was so that we could achieve that value-based purchasing exemption so that we could be at that same level of Medicare. And then also we have for fiscal 17 adjusted the domain weights, which I've already previously discussed. Next slide, please. So you'll see the total Maryland programs that are performance-based that have associated revenue at risk. We have on the top box of this graphic, we have our Maryland Hospital-Acquired Conditions Program. These are a set of 50 conditions that are not present on admission. And then we have 3% at risk for fiscal 17 for that program. For the Readmission Reduction Incentive Program, which is roughly analogous but not the same as the CMS readmission program, is 2%, and QBR is 2%. And then we also have that global budget revenue adjustment of 0.86 total statewide, and then a shared savings program, which is another program that's based on the level of readmissions. So all of those adjustments bring our revenue at risk for performance up to 8.72% in the state, whereas if you look down, you'll see for CMS it's at 6% for the Medicare payment linked programs. If you can move forward. So going forward, we really do need to develop an efficiency measure more similar to what CMS is doing. And we want to align our efficiency measure with population-based metrics. Currently, the staff at HSCRC is working to first drill down and clearly specify the component measurements needed to calculate cost per Maryland resident. And this would be very similar to what a payer does in per member per month or per member per year or per beneficiary per year, if you will, costs. And we do illustrate the general formula that is used to calculate such measurements. We will be working with a contractor and a combination of our staff going forward through the end of this year and next year in order to develop an efficiency measure that is robust and more comparable, but not exactly the same as is used with the Medicare program. Next slide, please. So what I'd like to just show you is our scaling model so that hospitals can see, again, so we can meet the spirit of hospitals seeing how they're doing during a particular measurement year. And if you can move to the next page, we do show a hospital-specific display. Now, this is modeling, and this was using fiscal 15 scores applied to fiscal 15 hospital payment rates using to display how hospitals would score for rate year 17 using this approach. So if we scale down, you'll see the top performing hospital has 2%, excuse me, the bottom performing hospital is 2% of revenue at risk. And then if we move this page down to the bottom, the best performing hospital would have 1% at risk. And then you multiply that percentage by inpatient revenue, and then you come out with the plus or minus revenue the hospital would gain or lose. In our program, it's not revenue neutral because we want to recognize going forward the achievements that the hospital has made. We do, again, use the better of improvement versus attainment scores, and that's what's used in the scores to calculate the points, which then are multiplied by the percent at risk, and then that translates into the revenue that the hospital gains or loses. And with that, I think that I will close and hand it back to the organizers of the meeting.
Thank you. Thank you very much, Diane, and thank you, Sandy. This is a lot of information, and I have to say for myself, some of this is very new, and it's starting to click. Lots of questions in my head, so I'm hoping that everyone on the line also has some questions. I did see some coming into chat. So I would like to, at this point, Ryan, can you let our participants know how they can pose questions over the phone?
The floor is now open for questions. If you have a question, please press the number 7 or the letter Q on your telephone keypad. Questions will be taken in the order they were received. If at any point your question has been answered, you may press 7 or Q again to disable your request. If you are using a speakerphone, we ask that while posing your question, you pick up your handset to provide favorable sound quality. Please hold while we wait for the first question.
All right, thank you, Ryan. So for everyone on the phone, that's 7 or the letter Q. And while we're waiting, I'm going to ask Carol if there were any questions in chat that we can pose. Carol, are you on mute?
Excuse me, Deb, and hello, everyone. No, I wasn't on mute, but, our phones time us out, so we have to recode ourselves back in sometimes. It just keeps us, the technology moves us forward and slows us down sometimes.
Well, welcome back.
I'm sure everybody's experienced that once or twice. So, we did have a couple of questions that had come in prior to our call, and I just want to remind everyone that if you do have questions, other than just on the phone and chat today, if questions come up during your team meetings or after the call, there's several ways to submit those. Of course, you can email Deb and I or Diane or Sandy, and they left their contact information in their slides as well. So one of the questions that was in the chat box, I think, Deb, was one that you asked, was 3M, using 3M. What is 3M's risk for mortality? So maybe Diane or Sandy could speak to that.
Sure. 3M risk of mortality, this is Diane, is it's a way to calculate risk of mortality and a hospital's relative mortality rate using the APR-DRG software that is implemented in the state of Maryland. And again, we use the 3M risk of mortality methodology to calculate hospitals' mortality rate or survivability scores, if you will, rather than using the CMS condition-specific heart failure, heart attack, and pneumonia 30-day measures, just because we don't have access to 30-day data when a patient dies after they leave the hospital. So it's a Maryland-specific thing, but 3M risk of mortality is embedded in the APR-DRG grouper software.
Thank you. Okay. And I think that there's another question that came in before speaking to, I think, in Virginia and Sandy's presentation on value-based purchasing. So when you mentioned the domain weight, on slide 5, I think was one place that was mentioned a couple of times, but on slide 5, you show that CLABSI is mentioned under safety twice. So once it stands alone, and it also appears in PSI 90 composite as PSI 07. So does CLABSI calculate into the value-based purchasing scoring twice?
This is Sandy. Don't forget, CLABSI, when you're talking about the safety domain, you're talking about NHSN data and you're talking about CERT. When you're talking about the AHRQ, the PSI 90 composite score, that's claims-based measures, so it's coded information that's submitted on the claim.
Okay, so whenever, is there two different ways that it figures into the overall value-based?
Yeah, it's looking at different data. It's looking at claims-based data versus CDC NHSN data.
Okay, but and I guess the way that the understanding is, if it's in the safety domain and also in the PSI 90 domain, would that be including both surveilled data and coded data?
Yes.
Okay. So there's we've had some discussion around why we would need to align coded data with surveillance data when we're working with our hospital teams. And so that would be another example of how those two data reporting mechanisms would need to align. Would that sound right, Sandy?
Exactly.
Okay, very good. Thank you.
Carol, I'd like to just make sure, Ryan, are there any questions in the queue?
Yes, we have 2 questions. The first question comes from Sheila. Sheila, please state your question.
I'm sorry, that was an error. Thank you.
The next question comes from Velva. Velva, please state your question.
I thought I saw the question on the chat where somebody asked how and where can we see the state of Virginia's comparison.
Sandy?
I'm sorry. I'm back on. Hi, Velva. Are you talking about the hospital compare website, the comparative data?
No, just like where Maryland was comparing theirs to the national and the national top 10%.
Are you talking about the slide?
Yes. That was Triangle 6, Maryland performance versus national benchmarks.
Right.
The process of care measures.
What we did was we pulled the data that was most currently available from lineupthebest.org, and that uses CMS data and methodology to calculate the results, and then you can pull in any benchmarks that you want. You can do the top 10%, you can do the average, and then you can look at a hospital, or if it's available on Hospital Compare, it's sort of like an analytic engine that allows you to pull it in and then make comparisons. So we just availed ourselves to that free tool that was available on the web.
Okay, thank you.
Can you share that, the web address for that?
Sure. It's just the words whynotthebest.org. And it's the Commonwealth Fund has established the website. We found it easier to use than the CMS Hospital Compare site, and since it uses the same source data, we thought it was just a nice tool.
And I believe that information is at the bottom of one of those slides, Diane, am I correct?
Yes, it is.
Okay, good. So it's spelled out there for you.
Yep.
Thank you.
Ryan, any other questions in the queue?
There are no other questions at this time. Again, if you do have a question, please press 7 or Q on your telephone keypad. Again, that's 7 or Q.
And so I think, go ahead.
We do have another question in the chat box, so I'll read that to our presenters. Is there any risk adjustment of type of test used? I believe for type of test used. For example, we changed to PCR testing in 2014 for C. difficile, which we expected an increase in capturing of CDI. Is that factored into a risk adjustment as opposed to using a less sensitive test for C. diff toxin? Very specific tests around HAI. So I believe that would that be something that would be calculated into the risk adjustment on reporting?
Is this for Sandy, for Virginia?
It wasn't specified, Jared, what state it was. I think both states use risk adjustment methodology.
Right. I don't think the CDC methodology accounts for the testing type. I think once you focus, this is Diane from Maryland, on a particular subject to measure it, once you start focusing on it, sometimes the rate goes up. And plus, if you use a more sensitive test that captures more infections, things might look worse before they look better. That's just a general observation. Not looking at the NHSN methodology right this second, I do not believe it accounts for test use.
I think it will take that into consideration moving forward with establishing this baseline in 2015 for NHSN, but that's not going to affect this payment that we're in right now. Correct, Sandy?
I'm sorry, what was the question, Deb?
That our measurement period right now, the fact that NHSN is going to be considering the type of test used in the risk adjustment for the SIR moving forward after 2015, that is not affecting our measurement period right now.
Correct.
Right. And I see we do have other questions which we are going to have to answer after the webinar. This is recorded today, so we're going to be sending out the recording. And with that recording, we will compile all the rest of these questions that are in chat. So if you have any other questions, please submit them in chat right now. I also saw that we did have the evaluation come up, so I hope that you've all filled out the evaluation, or will do that before you sign off today. I want to thank everybody, especially our presenters. This is great information for us all to have, and it helps us understand how our daily work impacts the healthcare reimbursement. We need to be up to date on how these programs work so we understand it. Every minute, I just want to close with every minute of every day in a person's life is a precious gift. So taking all of those minutes, any of those minutes away from a patient due to harm caused by the healthcare system, that's not fair to the patient, their family, their loved ones, or their friends. So let's keep in mind that the patient and family are at the forefront of why we do this work. VHQC encourages all of you to find ways to involve your patients and families in their healthcare decisions. So for those of you who are thinking about joining the VHQC HAI Improvement Network, we are still recruiting. It's not too late to join. Contact Carol or myself. For those of you who are already in the HAI Improvement Network, just remember that our next network call is May 12th at noon, and we'll be conducting our first network data review at that point. So we're expecting some lively discussions surrounding the network data, and I look forward to all your participation. So thank you all again for attending today's webinar, and have a great afternoon, everyone.
Goodbye.
Bye-bye.